Okay, let's bring the Committee of Health and Human Service back to order. Thank you, everyone. Um, So, Representative Morrison, please introduce yourself and your bill and your testifiers.
Thank you, Madam Chair. I'm Representative Kelly Morrison. Madam Chair, committee members, House File 1400 is a bill that establishes a verified interpreter registry for spoken language healthcare interpreters to replace its current unverified roster system. This bill is the result of ongoing stakeholder engagement efforts that have included providers, patients, limited English proficient communities, clinicians, interpreting agencies, interpreter member organizations, and independent interpreters. The bill has significant changes from previous versions brought before this committee at past legislative sessions based on the stakeholder engagement work that has been undertaken. It establishes 3 interpreter categories of training with minimum competencies. 1 core interpreter requires an examination in English on interpreter ethics, standards of practice, and basic medical terminology. 2 trained interpreter, it requires 40 hours of medical interpreter training and demonstrated oral proficiency in English and target language. And 3 certified interpreters are national certification or equivalent for rare languages in healthcare interpreting. Other important aspects of the bill include 3 hours of continuing education each year, procedures established for receiving and investigating complaints about identified prohibitive conduct and for imposing disciplinary or corrective action with interpreters' due process protection. It establishes an advisory council with membership representing a broad group of stakeholders, and there's a gradual 2-year roll-in registration fee that is not to exceed $90. The bill aims to address 3 major concerns that exist in Minnesota's limited English proficient communities. The first is healthcare access. Patients who do not communicate in English are entirely dependent on an interpreter to deliver the important medical information they need accurately and without additional advice that was not given to them by their physician. Second, it's addressing patient safety. There's been demonstrated evidence of the risk of medical errors and complications as a result of untrained interpretation. These questions are critical to the success of even a simple check-in, but can quickly go wrong if the interpreter is not familiar with basic medical terminology. Finally, this bill builds a foundation of training and professionalism for interpreters. The majority of Minnesota interpreters are already providing competent services to patients. However, there is no distinction made on the current state roster system for level of training an interpreter has. Right now, an interpreter with no training can register to be an interpreter on the roster. Their ability to do so continues to undermine the work of the rest of our hardworking and dedicated interpreters and agencies on the roster system. As a practicing physician, I have had the honor of taking care of many in our wonderfully diverse community, and I know firsthand how critical the services that medical interpreters provide is. This bill works to address this important public health issue by ensuring that our patients and interpreters are protected and valued. And I'm joined by Rosa Talk from the Minnesota Council on Latino Affairs, as well as Rachel Herring, sorry, Rachel, from Century College, and they will both provide, share more work about their agency, what the work their agencies have done on this bill.
All right, thank you. Welcome to the Health and Human Service Policy Committee. Please introduce yourself.
Thank you, Madam Chair and members of the committee. For the record, my name is Rosa Talk. I am the new Executive Director of the Minnesota Council on Latino Affairs, and I know that many of you might know me. Previously, I was serving as the Legislative Director in the area of health for the Council. Thank you very much for the opportunity to testify this afternoon during this informational hearing. My colleague and Executive Director of the Council on Asian Pacific Minnesotans, Sia Hare, was going to testify as well on behalf of my colleague and Julie Cameron, who is the lead staff for this piece of legislation in that council, but unfortunately Sia had to leave and Julie is out of town. So I'm going to try to combine both testimonies here in one, since our 2 councils have the same role, the same mission, and we have been, we are by statute here to advise, to inform, and to also make recommendations regarding issues that are important for our respective constituencies. So, and I'm not going to take too much time from Sia's testimony, since you all have already received a copy of her testimony. All I would want to say is that our two councils have been working on this piece of legislation for many years now, and we urge you that you consider to have a hearing during the next legislative session, and that you support this bipartisan legislation. I see here co-authors of our bill in the House. Representative Albright is one of them. Representative Serwa also is one of them. And in the past, also other representatives in both parties have supported this piece of legislation, both in the House and in the Senate. But this piece of legislation is very important for us, since of our combine the Asian Pacific Minnesotans and Latino Minnesotans. We are approximately more than 500,000 of residents in the state, and of those, 30% of them are considered limited English proficient. So this talks very personal to many of us, and this is why I think that making sure that those voices are recognized and acknowledged is important in this piece of legislation. So you have Ms. Hare's testimony with you, so I'm going to explain very quickly, so we have time for other testifiers to present their perspectives about this bill, since this is an informational hearing, and we're very glad that many perspectives are heard this afternoon. So as part of our role, as I was saying, in 2017 and 2018, our council, the Minnesota Council on Latino Affairs, we toured many towns across Minnesota, and we held 24 community listening sessions. And we found that the second top health concern for many Latino Minnesotans is the need for quality interpretation and more interpreters that are properly trained and qualified. Just last month, during a Latino festival in East St. Paul, we conducted a survey with community members attending the festival, and two women shared with us their unpleasant encounters at their clinic with some interpreters, and their frustration and distrust because of their lack of professional training. So this bill emerges from many voices and stories like this across linguistic and cultural communities. In the last 2 years, our two councils have engaged, informed, and held conversations with many stakeholders, including providers, patients, public health workers, interpreter member organizations, and independent interpreters. We talked with an Eritrean refugee woman in Worthington, with Somali public health practitioners, with a South Sudanese certified interpreter in St. Cloud when we visited your district, Representative, last year. And we also talked with representatives of immigrant communities, including the Black Immigrant Coalition. We talked with owners of small interpreting agencies, including the owner of a small interpreter agency in Wilmar. We also presented this bill to the Cultural and Ethnic Communities Leadership Council at DHS and the Metro Immigrant and Refugee Health Network at MDH. And finally, through the Office of Representative Noor, we helped convene a community conversation with mostly Somali interpreters in February of this year. So this third version of the bill captures and addresses previous concerns voiced by many stakeholders. We believe that this new language strikes a needed balance between a diversity of interpreters' needs and patient safety. For instance, in this new version, as Representative Morrison was indicating, there are no costs associated with the entry exam. The bill looks at funding to provide training. it doesn't impose entry to barriers. It doesn't impose entry barriers to interpreters. The registry is not mandatory, and it keeps registration fees as they are now, as it is now amended in SF Senate File 875. So what I want to say here this afternoon is that, as you will hear from many this afternoon, and as we have heard also through all this engagement process that we've been doing in the last years, is that a new system is necessary. And today, Minnesota has the chance to innovate and have a significant impact in the health and well-being of diverse patients by securing access to the same quality of care than everybody else. So thank you again for the opportunity to inform you about this bill that we strongly advise you to support. Thank you very much.
Thank you so much for your testimony. Please introduce yourself and who you're with.
Thank you, Madam Chair, ranking member and members of the committee. For the record, my name is Rachel Herring, and I am pleased to be able to speak with you today on the subject of HF 1400. To begin, I'd just like to let you know a little bit about who I am and why I'm here with you today. I have been working as an interpreter and interpreter educator for 15 years. I hold a Doctor of Philosophy degree in interpreting from the University of Geneva, and I work here locally in the Twin Cities as a Spanish language interpreter. And I am also currently the program director of the Translation and Interpreting program at Century College. Please do note that I am testifying here as an informed stakeholder and not as a representative of the college. A longer version of this testimony, including a bibliography, has been submitted to you in writing. Today, I'm going to take just a few minutes to provide you with some information and context about interpreting, about community or dialogue interpreting, and the skills and knowledge that go into this complex performance task. You may have heard of community interpreting, medical interpreting. Another name for this is dialogue interpreting, which is a type of interpreting that takes place when two or more individuals that do not share a language in common come together and need to interact, generally in a place that is an institutional or official setting. And these are interactions that are usually goal-directed, for example, getting medical care. They are interactions that inherently involve power differentials between the speakers involved. Usually a less powerful minority language speaker is seeking something, in this case, medical care, treatment, from a more powerful majority language speaker. And they are characterized by a number of different aspects. For example, the sensitive nature of the content, the potential for emotional or traumatic content, the inherent difficulty in communicating across barriers of language and culture. Interpreters, as they carry out their task, are faced with the challenge of dealing not only with language transfer, which is a complex set of cognitive tasks about which I could go on at length, but will not here today. But beyond those cognitive tasks of language transfer, they are faced with the need to deal with the social and interactional complexities that are inherent in any kind of communicative activity. They also are faced with the need to make a lot of decisions about a large range of factors that have very high stakes in a fast-paced and high-stakes environment. And in medical settings, of course, they're also faced with the realities of the sights, sounds, and smells that they may encounter on the job. This I will just note as a side note that I was listening to the previous discussions within this committee hearing this afternoon with my interpreting teacher brained on, and I've come up with a couple of exercises for my students to do based on what I've been hearing today. So as I was saying, the skills and knowledge that go into competent interpreting, high quality interpreting, go well beyond the ability to understand and speak two languages fluently. Interpreters need to, again, in addition to speaking and understanding two languages, there are a number of complex cognitive processes that they're carrying out. They also have to have good interpersonal and communication skills, the ability to understand and comprehend complex discourse that is often full of jargon or terminology that is specific to a setting. They have to deal with turn-taking and interaction of management, especially in situations where there may be multiple speakers of multiple languages who have differing goals and agendas for the interaction. They have to be able to deal with intercultural communication, awareness of potential differences in education, background, and cultural assumptions between speakers. In addition to this, they need to have a full and complete knowledge of professional codes of ethics and standards of practice, the ability to make decisions quickly in a high stakes and rapidly changing environment. And so my message to you is that achieving competency in interpreting requires dedicated time and focused practice that is aimed at developing these skills and knowledge, which are on the surface not entirely evident. I am used to hearing students, I am used to hearing individuals that I talk to say to me, there's a lot more that goes into this than I was aware. And that is true. So while some level of basic knowledge and skill may be imparted in a short training, I would also present to you the consideration that there should be an incentive for interpreters to continue to develop their skills and knowledge and to even seek higher education or tertiary education in order to improve their skills and to provide high quality care to all members of our community. There are more, I've shared more thoughts and recommendations in the longer testimony. I'd like to just conclude by saying that I greatly appreciate that the legislature is continuing to focus on this important issue. I hope that the process that we are going through will lead to a piece of legislation that is well crafted, that provides strong incentives for interpreters to continue to increase their level of training and competence, and that will contribute to the vital task of ensuring access to high quality services for all members of our community, regardless of the language they speak. I do thank you for your time and attention, and Madam Chair, I would just note, I don't know whether there would be any questions for me, but unfortunately I do need to excuse myself. So I will just note that I would not be available for questions at a moment later in the hearing. Thank you very much.
Thank you, Mrs. Herron. For members, do you have a question for Mrs. Herron before she leaves? All right, thank you so much.
Thank you very much. I appreciate your time.
Okay, can we have Joel Unlin and Sam Estes?
Madam Chair and members of the committee, my name is Joel Yulin. I'm the Associate Vice President for Public Affairs at UCare. I am also here today on behalf of the Minnesota Council of Health Plans. I just want to express our strong support for this bill. This is a bill that we feel does a number of things that will help in the community. First of all, one of the things that it does is that it helps with dealing with some of the healthcare disparities that are out there and making sure that there is proper access for all members to be able to go to doctor appointments or whatever may be going on and ensure that what is being translated to them is being done in a professional manner. Another part of this bill that we also are in strong support of is relating to Section 10 of the bill, and what that does is that it requires the Department of Human Services to take a look at developing a stratified reimbursement rate. And I think the previous speaker was kind of alluding to this as well, is that we want to be able to get to a point where we can recognize interpreters that have kind of gone above and beyond, and maybe they're taking on either a rare language or have taken their skill levels to a much higher level. We want to be able to be at a point where if there is the Department of Human Services is able to develop a stratified reimbursement rate that recognizes people who have gone above and beyond, so that way we're not having to pay one single rate for all situations. So again, we are in strong support of the bill, and I'd be happy to answer any questions.
All right, thank you so much for your testimony. Sam Estes? Okay.
Madam Chair and members of the committee, my name is Samuel Estes. I'm testifying today in support of House File 1400 to establish the interpreter registry system. I am a MNsure navigator at Portico HealthNet, a nonprofit organization dedicated to improving access to healthcare. I'm also a trained Spanish language medical interpreter. My roster ID is 89416. As a medical interpreter on the current registry, I fully support the increased professional requirements this bill proposes. I completed the 40-hour medical interpreter training through an interpreting agency in 2014. And with my current training, I would be eligible to be listed as a core or trained interpreter, level 1 or 2, respectively, of the proposed three-tier system. In my experiences as a medical interpreter over the past 5 years, I've come to appreciate the 40-hour training I received and continue to reference my training materials. It's really hard to imagine interpreting competently without this preparation. As the previous testifier, Rachel Herring, said, being bilingual in Spanish and English is certainly not enough to interpret well. And the interpreters that I know have either completed or want to complete interpreter trainings in order to improve and sharpen their interpreting skills. I also support this bill as in my work as a MNsure navigator at Portico HealthNet, where I help people access health coverage and health services. Many of my clients at Portico are folks who have limited English proficiency, or LEP, and need interpretation in healthcare settings. The establishment of statewide standards for interpreter testing and training in this bill would increase interpreter professional standards, which means better interpreting in medical settings and improved quality of care for LEP patients, a population that already faces barriers to accessing quality health care, as Representative Morrison mentioned. Such changes will ultimately empower LEP patients to make the best healthcare decisions for themselves and their families. Thank you.
Thank you so much. I'm going to mess this name up, but Dashraf Yata? And let's see here, Michelle, Lisa Gibson.
Hi.
Hi. Welcome to the Health and Human Service Policy Committee. Please introduce yourself and your name.
Yeah, absolutely. Madam Chair and members, thank you for hearing my testimony today. My name is Dasha Theatre. I am here to request your support for House File 1400 to create an interpreter registry in the Minnesota Department of Health. I am the program manager of SEVA AIFW, a non-profit 501c3 SEVA AIFW formed in 2004 to serve the underserved, vulnerable populations of immigrants and refugees in a cultural specific way. Our South Asian community includes a variety of languages and dialects. Asian Indian total 47,000 Minnesotans, making us second largest Asian immigrant group in Minnesota. We are also serve popular population from Pakistan, Bhutan, Nepal, Trinidad, Guyana, Tibet, Bangladesh, and Caribbean diaspora. Our staff is all bilingual, many trilingual, and received training to interpret for our clients in the language they understand. All of our staff is registered on the interpreter roster. SEVA AIFW has been a resource for Minnesota lawyers, courts, and health clinics and hospitals in understanding our South Asian community in Minnesota. Working in Minnesota for several years has given me first-hand experience of the disparities that exist in the interpreting. In our work with community, we have been frustrated. There are no checks and balances for patients, agencies, clinics, or interpreters on skills, even the language that they speak. A verified registry system prevents simple mistake in communication from happening at the cost of state dollars and the patient health. In one case, a member of our community was sent to interpret for wrong Asian language as a mother was delivering her baby. The clinic had no verified record of her interpreting skills, or more importantly, her inability to interpret the mother's language because there is not a verified system in the place in Minnesota. To her horror, the interpreter realized she was selected to interpret for the wrong language. She was told to simplify, do her best, but there was nothing she could do. She felt betrayal for the patient and her soon-to-be-born baby. She was powerless to help the mother. Luckily, the father arrived and was able to interpret, and the delivery had no complications. Cases like that inspire us at SEVA to do more for our community and work for nonprofit organizations to help them. It still haunts us to know that a mother and her newborn baby were put at risk because a qualified and appropriate language interpreter was not there to help them. However, there are still no standards in place to protect our patient. We have limited capacity as a community organization to provide our direct service program to South Asians and also provide additional interpreting support. If we send a client to an appointment, we need to know that they are safe in the hands of qualified interpreter. Many interpreters work hard and have gone through trainings, but some do not. Without a verified registry system, we do not know whether our clients will get the help and support they need from their physician. We are you to support this legislation. Thank you for your consideration. And my humble request is, those who are finished in the mother language 14 years or 15 years, I think they no need to get the training, official training. So that is my appeal. So MDS should be considered this exemption. So I qualified person in Telugu in our language almost 15 years, 20 years. No need to get the training certificate from the interpreter institutions. So that is my appeal to committee.
Thank you so much for your testimony.
Thank you.
Okay, Lisa Gibson, please.
Madam Chair and committee members, thank you for hearing my testimony. My name is Lisa Gibson. I work at the Karen Organization of Minnesota. I work with our interpreter training program, which is funded by a deed grant. And I'm here to support the establishment of an interpreter registry in Minnesota. I'll tell you a little bit about our organization. We are led by Karen refugees who came to the United States fleeing civil war in Burma. There are currently an estimated over 15,000 refugees from Burma living in Minnesota, and KOM responds to the community's high need for services in their own languages. We have a variety of health education programs, MNsure assistance, and other job trainings. Last year, our staff served over 4,500 walk-in appointments who simply needed language support to read mail and navigate services. We know that the need for language assistance is extremely high. And we support the bill to create a registry that requires interpreters to have some level of proven qualifications. And as Rachel Herring alluded to, we would like to continue to work with the authors of the bill to make sure that the language is correct. And we know that this bill is important to the Karen community's ability to receive the same quality of medical care as the English-speaking population. A colleague of mine at KOM related this story that a Karen community member was going to the dentist with his untrained interpreter who did not understand the procedure that the dentist was explaining. The interpreter did not know medical terminology or know to ask for clarification, so he told the patient that the dentist was going to help him and to go along with whatever the dentist recommended. At the end of the procedure, the patient and interpreter realized with horror that the patient no longer had any teeth. Oh. Fortunately, in this case, there are dentures to replace the teeth, but that is not the case for every medical complication caused by an unqualified interpreter error. So thanks again for hearing this testimony, and thank you for your support of this bill.
Thank you so much for your testimony. John Quinn and Michelle LaVon. Let's see. Ms. Talk. Rosa, can you make the other seat available for the other testifier? Thank you. Thank you. Welcome to the Health and Human Services Policy Committee. Please introduce yourself for the record.
Thank you, Madam Chair and committee members, for allowing me the opportunity to testify today. My name is Michelle LaVon, and I am the owner of Multilingual Word, a company which has been serving patients since 1995. I am here today on behalf of the IAM Interpreter Agencies of Minnesota, a trade association that represents interpreter agencies that provide interpreter services for tens of thousands of healthcare visits in Minnesota each year. As a past member of the Interpreting Stakeholder Group Training Committee, I am a strong proponent of quality in the field of interpreting. Interpreters play a critical role in the delivery of healthcare services to patients that do not speak or understand the language of their healthcare provider by reducing linguistic barriers in communication. We have been in conversations with Senator Wickland for a number of years now, and we appreciate her efforts to improve the quality of healthcare interpreter services. We share her and Representative Morrison's goal of assuring that every patient visit which uses an interpreter results in accurate information being provided to both parties. When I last testified in this body on this issue, we had many serious concerns. However, some of the amendments on the Senate version from the last session have incorporated our suggestions into the amendments, and we believe that we are much closer to finalizing a bill that addresses the concerns that have been raised about interpreter proficiency and quality of services. For example, we are pleased to see the core level tier, which addresses the issue of the shortage of interpreters available, especially in the less common languages, and assures access to a qualified interpreter for members of all of Minnesota's diverse communities. We also believe that this legislation closes a massive loophole which had existed in previous versions where Minnesota face-to-face interpreters would have been at a disadvantage to non-Minnesota interpreters providing remote telephonic and video interpretation. The current version now seems to apply the same education and quality standards to both remote interpreters as to the interpreters located within the state. Again, we believe we are close to finalizing a bill that addresses the needs of patients, interpreters, and clinicians. We do have some specific suggestions to improve the bill even more. We believe that the eventual increase in fees to $70 and then to $90 for interpreters to join the registry starting in July of 2022, compared to the initial fee of $50 in accordance with the current Minnesota roster fee, will place a financial strain on interpreters and could have the unintended consequence of reducing the pool of interpreters, specifically for rare language interpreters who may only have a few assignments per year. In addition, we would like the late fees to be eliminated, as independent contractor interpreters often go through periods when they are unavailable. We are also concerned that the commissioner may have too much power to have unilateral authority to set and change fees, and would appreciate the opportunity to discuss the fee structures further. We also want to make sure that monies collected for interpreters will be used solely for the benefit of interpreters and not for any other purpose, as has been the case with the existing roster, which has been seen by many as a tax on interpreters with no value to them. Interpreters should experience an advantage to being on the registry by offering such benefits as scholarships to improve skills and help in accessing low-cost or free continuing education opportunities, for example. The end result will be an increase in the quality of the interpreter pool in Minnesota and will ultimately benefit the patients and providers they serve. Since the legislation impacts interpreters directly, we would like to see even more representation of interpreters on the advisory council. We recommend at least one more interpreter and one more representative from an interpreter agency to be added as part of the advisory council. Again, Madam Chair and committee members, I appreciate this opportunity to testify today and would be happy to answer any questions which you may have and provide more specific suggestions for the committee's consideration for possible amendments as the bill proceeds.
All right, thank you so much for your testimony. Please introduce yourself to the committee.
Thank you, Madam Chair and committee members, for allowing me the opportunity to testify today. My name is John Quinn. I'm the Director of Operations for Multilingual Word, and I'm here today both as a concerned citizen and as a representative of the interpreter agency that I manage. Multilingual Word takes great pride in providing the highest quality local interpreters. We vet our interpreters through background checks, ensuring that they are professionally trained whenever possible, and that they are registered on the Minnesota Department of Health roster. This hearing is to discuss the bill to establish a registry system that would replace the Minnesota Department of Health interpreter roster. I do fully support the registry and the bill. In my discussions with interpreters and other stakeholders, however, we have identified some serious issues and pitfalls with the current roster system that need to be addressed in this new legislation. The roster information currently contains private information for these interpreters that is not protected, it is not encrypted, and is available to anyone that has internet access. This information has been utilized by companies outside of the state of Minnesota to obtain a list of interpreters that these out-of-state companies can then claim to have as contract interpreters, allowing these companies to bid on contracts for language services inside the state of Minnesota. There have been several instances of these companies winning contracts, then contacting interpreters from this list, sending these interpreters to appointments, and then not paying or delaying payment to these interpreters. Interpreters are taxpayers. They're citizens or resident aliens that have the right to work in the state of Minnesota. However, their information is made public, opening to them the possibility of harassment, fraud, and in some cases, even alleged stalking. These interpreters also pay the state of Minnesota for the privilege of having their information publicly displayed. In addition, the funds that have been collected by the state of Minnesota through the Minnesota Department of Health roster for spoken language interpreters have not been spent to positively impact the professional interpreters or the citizens of Minnesota that utilize interpreter services. The Minnesota legislature should be open to establishing a spoken language registry system that provides clear value and protection to these professionals and to the community members that they serve. Thank you again, committee members and Honorable Chair, Madam Chairman, for allowing me to speak today.
All right, thank you for your testimony. Okay, we have two more testifiers, Isabel Montanez, Isabel, and Elisa Gusterson. Welcome to the committee, and introduce yourself for the record.
Thank you, Madam Chair and members of the committee. My name is Isabel Montanez, and I am a certified medical interpreter. I graduated at the University of Minnesota from the program in Translation and Interpreting. I work at HCMC hospitals and clinics, and I am the president of UMCHA, the Upper Midwest Interpreters and Translators Association, which is also the chapter of the American Translators Association. UMCHA's mission is to provide high-quality continuing education to all interpreters and translators in the Upper Midwest. We promote professionalism, training, and education to bring high-quality interpreting and translation for the safety of limited English proficiency population in our area. I am here to explain the reasons why UMCHA does not support the HF 1400 bill. First, it does not require high school education. Second, it does not require oral proficiency testing for interpreters of languages of lesser diffusion. Third, it does not stipulate a pay differential between untrained and certified interpreters. Fourth, the continuing education credits required here are too low. Fifth, we considered that the advisory council should include 8 interpreters of diverse languages. Sixth, we consider that the fees of the registry should only be used to benefit interpreters for training and testing. And now, for the safety of our patients and the continuing improvement of language services in Minnesota, we would like to see a registry for professional medical interpreters that includes higher standards requirements. We want a registry that offers a voice to all interpreters. Thank you for your time.
Thank you so much for your testimony. Please introduce yourself for the record.
Good afternoon, Madam Chair and representatives of the committee. Can you hear? Is
Yes.
the microphone work? My name is Elisa Gusterson. I have been a healthcare interpreter for 18 years. I am an ATA certified translator, a CCHI certified interpreter. I completed the TRIN program that Isabel alluded to doing at the University of Minnesota and was an instructor in that program for 6 years. I have been on the board of AMSHA from the year 2007 to the year 2018. And I would like to fill you in on some of the current and historical information that maybe is unknown to those of you who aren't in the field of interpreting. For one, I have served as a subject matter expert for the creation or the development of the national certification exams that are the tier 3 of this proposal, which is being proposed at the highest level. As such, I know that the questions in that exam, the exam is prepared for an entry-level interpreter. So we are developing a system where the highest level is entry-level. The certifying organizations also have their own requirements for continuing education, which we must periodically submit then to them. Therefore, having the registry again request that we submit our continuing education is duplicating efforts. Third, currently almost all interpreters that interpret in healthcare in Minnesota have completed the 40-hour training course. Do you know how that came about to be? That was because the hospitals began to require it from the agencies that sent them interpreters. And so all of a sudden, the market itself made it necessary for interpreters to take that 40-hour course. No legislation was passed. It's almost standard right now. It makes me wonder how many other advances and qualifications could be implemented in this manner without the bureaucracy and the cost of this registry proposal. How many other improvements could come about if only hospitals and agencies were willing to pay a differential for higher qualifications? We are making a system for the lower bidder, creating a large pool of minimally qualified interpreters. Many Minnesota school districts, on their own initiative, have already implemented higher pay rates to interpreters with more training. And in this case, we're talking about people who have done the courses at the U of M, not just a 40-hour course, usually. Interpreters' real income is not adequate to retain qualified interpreters in the field, nor does it allow for time and investment in training. If we want better trained interpreters, we need to make sure they are paid enough to do so. The OPI level of advanced mid which is a level required by the registry when it is tested, is defined as someone who is unable to converse in abstract subjects across all topics or in time frames other than your basic past, present, and future. So we're talking about a pretty basic level. Above that, we have advanced high, superior, and distinguished. So interpreters who are in this system are only screened, I would say. We can't say we have a qualified interpreter through this system. So what I would like to see, what other interpreters like to see, is a registry or the roster converted into a verified database. This database could confirm and post background checks, training, certifications, language testing levels, as well as college degrees, other areas of expertise, other certifications. It would have all the transparency that is needed. It would not require a huge machine to function and would not create a huge burden on interpreters. Those who hire interpreters would then be able to choose what level of training and language skills they wish to require, considering what is available for each language. And interpreters who are interested in being hired would be motivated to increase their qualifications. It could be a stepping stone for direct contracting with interpreters with no intermediaries, no agencies, which is something which Washington State already does. So when we look at this current registry proposal, the question I ask myself and others ask ourselves is, who does this benefit? We've talked a lot about the patients here. But why are the interpreters paying for this when it seems it really benefits agencies, hospitals, and health plan companies? If the registry proposal does prosper in spite of my observations here, I would at least ask reduce the cost. Oregon has a registry that works very well for $25 every 3 years, not $50 and $90 every year. Reduce the bureaucracy. Annual renewal is too much. Make it every 3 years with we're requiring a lot of paperwork and a burden of charge to the interpreters. Having to present continuing education if you're already certified is redundant, and for the government and for the interpreter. Include measures for a livable wage so that unqualified interpreters may guarantee that they'll get something better than if you're not qualified. As I say, this system only generates many screened interpreters. It doesn't really guarantee qualifications. And last, on a maybe minor issue, the core interpreter maybe should be called an aspiring interpreter, because without language testing, the basic element of definition of an interpreter, we really can't know if they're an interpreter or not. So thank you for listening to my testimony, and I will be happy to answer any questions.
All right, thank you so much for your testimony. Members, do you have any questions for the testifiers? Representative Loeffler.
Well, it's not so much a question for the testifiers, it's just a comment on the bill, and that under the advisory council responsibilities on 5 on line 10.14 is to advise the commissioner on methods for identifying gaps in interpretive services in rural areas and make recommendations to address training and funding needs. And I would say I wouldn't limit it to rural areas. I would say in different geographic areas of the state. While we have less refugees coming in now because of federal policies, it has been tradition that more of the refugees from unusual locations with unique language needs have tended to settle in the metro area first. Now they might disperse later. And it was interesting to hear we have 15,000 Karen people here now, but I remember it was 15, 20 years ago when the call went out in panic because Anoka County was taking responsibility for a large number of Karen speakers who were coming in a plane the next day, and they were desperate to try and find anyone who could interpret Karen. And so they were contacting other counties and all kinds of people trying to figure out networks for someone who could do that. And my understanding is they found an undergraduate student at the U, and I always thought it'd be interesting to hear how his life changed when he suddenly was told that he had this whole big group of displaced people whose settlement might be dependent, at least for a while, on his willingness to kind of drop things and help them out. And so I do think that we need to look at all areas of the state and wherever they come from, because I think the most challenging ones sometimes are the people who, when international groups divide up, Britain's taking this many, Canada's taking this many, the U.S. takes this many, and Lutheran Social Services or some nonprofit in Minnesota steps up. We don't get much notice.
Okay. Representative Albright.
Thank you, Madam Chair. So a couple questions for the chief author of the bill. One of the observations I have about the council itself is it doesn't specify the term for each person on the council itself. And if there isn't a length of term on the council, my estimation is that you could stay there as long as you wanted to. And we are looking at, as has been evidenced by the testifiers, a very, very diverse constituency that certainly would want to have their voice heard, if not initially, with the hope that they might. And so I would just encourage you and the others, the stakeholders, to look at defining the length of terms for those members. It seems like, and I remember in the last biennium when this bill came before the committee as well, the idea of the fee structure continues to be a stumbling block. And I don't know if it was Ms. Montanez or Ms. Gusterson that said that the Oregon and the Washington models seem to have solved that without really much in way of intervening by the state itself. And I'm wondering, even, to take it one step further, if the various constituencies that want this, why wouldn't they be able to put this registry together themselves without the need for the state to establish it? One of the questions I have is, the fee structure is going to support the registry itself. So my question is, how many FTEs are you actually thinking about? And do we have any idea? I know this will be the part of the Health Finance Department, and there's appropriations with blank lines on page 13. But, I mean, what are we estimating for the number of people that would be wanting to be on the registry? If it's only 500, that's not a lot for the state to, hire a couple people. So I'm just wondering if, as a suggestion, maybe the coalition itself should band together and put this together on their own, and then they can decide how to govern themselves, to police themselves, and also, as Ms. Gustafson said, to, rather than screen applicants, actually provide for qualified candidates to the people who so sorely need them. So it's needful, but we only really have one opportunity to do this right before we send it on its way, and we should make every effort to do it the right way the first time.
So I'm going to have Mrs. Carvis to respond to some of your questions, Representative Albright.
Madam Chair and Representative Albright, I just wanted to point out that the Advisory Council is governed by Section 15.059, and that provides in part that the term of Advisory Council members is 4 years.
Perfect. Thank you.
All right, Representative Freiberg.
Thank you, Madam Chair. Ms. Clarkvist beat me to it. I might be the only person in the world whose ears perk up when issues like term limits of advisory council members gets brought up, but that is an issue in the purview of the Government Operations Committee, so I figured it would be in on line 10.2. It references section 15.059, which
And you
would
have
answer
to
the
be
question.
the chair of that, right?
Yes.
All right. Is any other questions? So I would just like to say that this bill has been around for a while. Really, I don't know whether or not you've spoken with the Somali community. Do they have any concerns about this bill?
Madam Chair, as several of you have now referenced, this bill has been around for a while, and part of the challenge, I think, has been trying to find common ground among the many different communities that are affected by it. Yes, the Somali community has absolutely been a part of the stakeholder conversations. I'm not sure why we don't have a representative here today, but Representative Noor and Representative Hassan have both been involved in community conversations as well. But I think some of the testifiers and some against, and then some of the testifiers who testified in support of the bill had suggestions too. So this is an ongoing conversation as we try to find the best possible path forward. So I appreciate everyone's suggestions.
Well, I want to thank you for bringing this bill forward. It has been around for a while, but we know medical interpreters, this is a matter of someone's life. It could be life or death. So we need to get this right. So I would like to really suggest to everyone who showed up, whether you are in support or in opposition or have suggestions for this bill, to work with the chief author to get this right. Let's get this right and let's move this in 2020. That's the only bill that I'm confirmed about how we need to move on this, but I think we need qualified people interpreting medical terminology when it comes to patients and doctors. So let's get together with the chief author and let's make this happen. Thank you. Thank you so much for bringing this bill forward.
Thank you, Madam Chair.
So we have our last bill. Representative Baker, thank you so much for hanging in and hanging around. And we're excited to have you come forward and introduce your bill, House File 1247.
All right.
Right, before you start, Representative Baker, I have a quick announcement. For all remaining testifiers. Please remember to complete the testifier sign-in sheet at the testifier table because our pages, our legislative assistants who's acting as pages need to leave. So we need you to have the due diligence to make sure you sign yourself in. Okay. Thank you so much for your help. Representative Baker, please.
Thank you, Madam Chair and members. I know it's running late, so we are going to try to move this along as quickly as we can. I know this is an important issue as well, like all of them in front of you today. And we'll be ever so brief. I've actually, and again, I've asked my testifiers to respect everybody's time It's almost at the end of rush hour, so that's going to help now anyway. So I just want to say I'm here on a very proud moment to be representing the Lions Club of Minnesota. They, if you don't know, have been doing the Lions Eye Bank in Minnesota for the last 60 years. And have been their mission in their life has been to get rid of the disease of blindness for the last 90 years as a countrywide mission. So I'm really proud to be sitting here with them today, and we've got some interesting concepts, and we present House File 1247 to talk a little bit about what it's like to do the eye procurements and the corneas and all that goes behind it. And I still don't know today how in the world I carried this bill, because I don't have that experience with this type of thing. But I will tell you, this is an important bill that we have to look at the future of how we handle this item in our tissue, in our way we have this medical science working so well for us, and how we've learned from this through the great people of the Lions and what they've done. So I'm going to let my testifiers do most of the speaking, but I want to make sure I just mention this up front. I want to be clear that the folks that are going to be against this tweaking of a bill, and why is government involved in this, is because it's not about profit or not profit. There's a company that's out there doing some really good work called LifeSource that we'll be hearing from today. They do amazing work. They do a lot of good harvesting and procurements of a lot of things outside of the cornea. So I want to make sure this isn't a us versus them, but it's about the process, and it's about research and how we want to move forward as a state of Minnesota, and how when we look at our legislation, we need to learn to support the groups in Minnesota that have done this at a nonprofit level, and over half of their work has been going into research with the tissue that they have. I'm going to turn it over to Lyon Lyle and have him kind of go forward with this, and Madam Chair, I'll stand for questions at the end, so thank you.
Thank you so much. Welcome to the Health and Human Service Policy Committee. Please introduce yourself for the record.
Thank you, Madam Chair and committee members. My name is Lyon Lyle Goff. I've been a Coon Rapids Lion for 15 years, and for the past 5, I've been on the Minnesota Lions Vision Foundation, and I've served as the chair for the last 3. And I'm here to state our position in support of Bill HF 1247 in regards to the nonprofit status for eye donations. I understand there's going to be talk about a revision of the proposed bill that was originally submitted last session. The 3 points I wish to make in regards to supporting this bill is, first of all, we have the Lions wish to preserve the altruistic nature of eye donations and feel that the majority of the general public would not be in favor of having their eye tissue sold for a profit by a company. At SET, we feel that this has been a workable model for quite a few years. We've been in the business for 60 years, and we feel that the general public is supportive of this notion. Second of all, we feel that the focus by the competition out there on cornea-only corneal procurements would deeply impact the research that's going on. For example, corneal transplant, obviously, it cures corneal blindness, but a corneal transplant does not address anything such as age-related macular degeneration, glaucoma, blindness caused by diabetes, retinitis pigmentosa, or any other ailments that impair the vision. Only through research using donated tissue will help eventually find treatments and ultimately a cure for these illnesses. So we're very supportive equally of tissue for transplantation as well as tissue that's available for research. Finally, we feel that this for-profit model for corneal transplantation would run the risk of having the pass-through through Medicaid to Medicare be impacted. That would turn corneal transplants over to be nothing more than something that the rich could afford, because right now the prices are pretty much set by the government on that. I'm available for questions afterwards, and I thank you for your time for allowing me to testify in front of this committee.
Okay, thank you so much for your testimony. Please introduce yourself.
Thank you, Madam Chair, and thank you, members of the committee. My name is Joshua Ho, and I'm a faculty member at the University of Minnesota. I'm a corneal transplant surgeon there. I'm also the medical director for the Lions Gift of Sight Eye Bank, which is the local eye bank in Minnesota. I just want to provide a brief statement today in this testimony in support of the bill in front of you, 1247. Basically, a bit of background. The eye banking system in the United States has been the crown jewel of eye banking across the world. We are the envy of every other country because of how robust our eye banking system is. For 65 years, there's been a collaboration between surgeons and local eye banks to create the best possible system for getting corneas to patients and having the corneas prepared in a good way so that they can be transplanted into patients. For 65 years, this system has been built on innovation and continual feedback between surgeons and eye banks in this local nonprofit system. This changed in 2016 when an eye bank in Seattle, actually the largest eye bank in the country, started a for-profit subsidiary to process and distribute their tissue, meaning that the eye bank was going to distribute tissue now for profit. Since 2016, that for-profit eye bank has moved into Minnesota and started to export tissue from Minnesota to Seattle, where it is then processed and distributed by the for-profit entity. This bill is addressing that current situation, and it is being proposed by the Minnesota Lions because of their concerns with the ethics and also the practical implications of what is going on. My purpose here is coming to you as a surgeon. I'm not necessarily a legal expert, so I would like to preface before I start with one thing. Back in May, when there was a similar bill in front of the Omnibus Committee, I did send an opinion letter to the committee stating my opinion about the situation. And in that letter, I did make a mistake in one of my misunderstandings of the National Organ Transplantation Act, the NOTA Act of 1984. I misquoted it saying that it banned the sale of organ, but not the sale of cornea. In fact, it does ban the sale of organ and cornea and eye for valuable considerations, but it allows for payments for processing and distribution, things like that. So I just want to preface that I made a mistake in stating that, but what I'm stating now is, again, my opinion. So in terms of what I wanted to come before you and say is basically given the situation where we're now starting to export tissues from Minnesota to Seattle and tissues are being now processed and distributed for profit, there is a rising concern among surgeons and eye bankers throughout the country, as voiced by the Eye Bank Association of America, that this system is detrimental to surgeons, patients, eye bankers, and donors. There are many practical concerns that I want to go over. Well, number one is there's risk and concern that donor trust in the whole system will be eroded as they realize that more and more of their tissue is being sold, not sold, but distributed for profit. And that could affect the donation numbers. Number two, with the local eye banking system that has been in place for 65 years, and like I said, is the crown jewel of eye banking across the world, you have access to emergency tissue and you have this close collaboration with the surgeon and the eye bank to ensure that you have available tissue whenever you need it. At the University of Minnesota, I do almost one emergent transplant, corneal transplant a week. We constantly have patients who come in who need emergency transplant tissue. I need the cornea within 4 hours. Any subsequent delay in the surgery is vision lost and potential risk of never recovering sight. Cornea is being sold to Seattle. Yes, they can be shipped overnight. Yes, you can schedule surgery. And if you need a transplant surgery a month out, yes, you can schedule it ahead of time. But there is significant concern among the surgical and eye banking community that without the local nonprofit system that already exists in place, we will not have this kind of access to emergency tissue, which is critical to the care we give to our patients. Number three, I think Lyle touched on this, but there's a concern that there is, as this model for-profit eye banking starts to take hold, is that the federal government will reevaluate how corneal transplantation tissue is reimbursed. Currently, Medicare and Medicaid pay 100% of the cost of the tissue. So whatever the nonprofit eye banks say it costs to procure, process, and distribute the tissue, they are reimbursed 100%. Now, if the eye banking model shifts to a for-profit model, and obviously there is some, either through inerments or other mechanisms, some benefit to shareholders in the for-profit company, it may lead to a reevaluation of the automatic pass-through that guarantees insurances reimburse transplant tissue. And if that happens, and insurers now bid for the prices that they're going to pay for tissue, and surgeons now have to hunt between eye banks to see who can give them the best deal, you start to really commoditize corneas. And at that point, you start to risk cornea transplantation being a luxury that only those with means or the right insurance can have access to. And that is a major concern of surgeons and eye bankers. And the final thing, which I think is a practical implication, is the risk to research. The University of Minnesota has benefited significantly from the donation of research tissue from the Lions Gift of Sight Eye Bank, but we also support heavily the research that's at Mayo. We support research all across the country that is directed towards finding cures for blindness. And we focus on all forms of blindness, even corneal blindness, diabetes, macular degeneration, glaucoma, the leading causes of blindness in the country right now, macular degeneration, diabetes, and glaucoma. And the thing about research is it is not profitable. So our eye bank really supports research at what is essentially a loss. A cornea that is distributed for transplantation is reimbursed about $3,000 to $4,000 by insurance companies. And like I said, that's an automatic pass-through. Research tissue that we send to a researcher is reimbursed from their grant money, maybe about $200 to $300. The disparity is huge. There is very little appetite for supporting research in a for-profit model. Now, the for-profit eye bank in Seattle does, in fact, engage in research for their own product development. So excess tissue that they procure, tissue that doesn't clear for transplantation, of course, they find uses for it in research to develop products that they have for their targeted market, which is corneal transplantation. But we're talking about a broader mission for eye banks historically, which is the cure for blindness and addressing diseases like macular degeneration, glaucoma, and diabetes, which many in the room will go blind from. And that is supported by what is not financially a fantastic idea, which is distributing research tissue. But it is what has been a major commitment of nonprofit eye banks and is a major commitment of the Lions Gift of Sight. In fact, the Lions Gift of Sight Eye Bank is #2 in the country among all the eye banks for distribution of donor research tissue. And it goes to the University of Minnesota, it goes to Mayo, and it goes all across the world to researchers who are on the cutting edge to solve vision loss. This is something that will be impacted if we continue to support for-profit eye banking because, like I said, it is just not as profitable as transplantation tissue. Based on these 4 points, the Eye Bank Association of America has publicly made statements supporting local nonprofit eye banks, which has been the status quo for over 65 years and has led to the innovations we have today in corneal transplantation, the tight partnership between surgeons and eye banks, and the current system, which basically every other country in the world envies. And so we're here because of this bill, because of the recent change in eye banking in 2016 and the new foray into Minnesota to extend that eye banking system. And we are asking for this bill to be passed in consideration of that in order to protect what we believe is a superior nonprofit model for eye banking.
Thank you so much for your testimony. All right, welcome to the Health and Human Service Committee. Please introduce yourself for the record.
Madam Chair and committee members, my name is Sean Popoff. I'm the Executive Director for Lions Gift of Sight. It saddens me to be here on the eve of the 60th anniversary of Lions Gift of Sight. Since January 2018, I've been directly involved in all aspects of the eye bank. First as administrative liaison for the University of Minnesota in my role as Department Administrator for Ophthalmology and Visual Neurosciences, and more recently in my new role as Executive Director for Lions Gift of Sight. Dr. Ho described how vital Lions Gift of Sight is for treating Minnesotans for advanced corneal disease by providing high quality and cutting edge corneal tissue for sight restoring and life-changing surgeries. As Dr. Ho stated, in addition, we provide customized tissue for research, not only to researchers at the University of Minnesota and Mayo, but to researchers throughout the United States and Europe. We are by volume the second largest provider of tissue to researchers' efforts to cure debilitating diseases such as age-related macular degeneration, glaucoma, and retinal diabetes. Our efforts have been lauded by the immediate past director of the National Eye Institute at the National Institutes of Health, and I will quote him, "Obtaining human ocular tissue for critical research is already at the edge of being cost prohibitive, and I want to resist commercial impulses that would add to the cost. I'm a strong supporter of local tissue and organ processing, as timing is absolutely critical for maintaining a source of high-quality specimens for research. The Minnesota Lions Eye Bank, and now the Lions Gift of Sight, have been the preeminent sources of eye tissue, procuring and placing high-quality specimens with internationally recognized researchers. That is from Dr. Paul Sieving, again, immediate past director of the National Eye Institute. I am proud to share with you that Lions Gift of Sight finds a home for nearly every tissue we recover, be it through clinical use for Dr. Ho and 35 other corneal surgeons, cure-producing research, or training our staff as well as the next generation of ophthalmologists and corneal surgeons. I am concerned that if SightLife and CorneaGen become the only eye bank in the United States, that researchers, in pursuit of cures for all blindness, will lose access to tissue supporting their research, as this model does not clearly fit in the for-profit world of SightLife and CorneaGen. At a recent meeting, LifeSource asked me what would happen to these legislative efforts if LifeSource announced they would only partner with not-for-profit eye banks. I appreciate the question, but our legislative efforts will not stop, as this effort is not about LifeSource. This effort is not about a fear of competition, and this effort is not about a turf battle between two local organizations. Rather, this legislation is about the altruistic gift of sight that our donors and families have graciously given. Minnesota is being watched by other eye banks and other organizations throughout the United States, and we have an opportunity to set a new standard in protecting this altruistic gift. Therefore, I find myself in a position today to ask you to stop the commodification of donated eye tissue in Minnesota, and hopefully by extension the United States, that is being pursued by for-profit eye banks. Thank you for your time.
Thank you for your testimony. Please introduce yourself for the committee.
Thank you, Madam Chair, members of the committee. My name is Phil Griffin with Ewald Consulting, and I'm here to present a statement by Dr. Eric Van Kuyk, who is the professor and chair of the Department of Ophthalmology and Visual Neurosciences at the University of Minnesota. Dr. Van Kuyk is out of the country and asked me to read a statement. I'm going to forward that statement to you in writing, but I just want to repeat that line that Sean used, which is the closing line of Dr. Van Kuyk's testimony. We are here to ask you to stop the commoditization of donated eye tissue in Minnesota that is being pursued by LifeSource and their carefully chosen partner. Thank you.
Thank you so much. So Dr. Hugh has a flight to catch, so I want to open it up for members who may have a question for him. If not, Representative Edison.
Thank you, Madam Chair. Could you just clarify again when this change that LifeSource started to have the eye donations come to them? When did this happen again?
Yeah, so the for-profit eye bank was established in Seattle in 2016. In January of this year, LifeSource January of 2018, LifeSource canceled their contract with UPS and their partnership with the Lions Gift of Sight Eye Bank, and pursued a different partnership with CorneaGen, which is the for-profit eye bank in Seattle.
And you've seen thank you, Madam Chair. You've seen a significant reduction in the amount of eyes that you've been receiving, or eye donations?
Dr. Ho?
Yes. So the way the eye bank gets referrals for eye procurement is through contracts with hospitals, and we have lost, I think, about a third of our contracts. Sean can speak specifically. He's the executive director for the eye bank.
Madam Chair, if you could tell me which hospitals have no longer discontinued their contracts, would be great.
We might have to bring someone else up to address the specific hospitals. I
Please
think the biggest concern
yourself for
again
the
is,
record,
I'm
too.
sorry, Madam Chairman, Sean Popoff, Executive Director for Lions Gift of Sight. I think we have welcomed this competition, and we've been able to do a lot of internal changes and to still meet the demand for the clinical tissue in our eye bank. It is very difficult at times. Where the impact has been felt the most is if you take the number of the hospitals that we lost between Minnesota and by extension through our relationship with LifeSource North Dakota, we lost, I think, 987 research tissues. From calendar year 2017, if you look at the numbers from the hospitals that we lost, it's 987 or 986 research tissues. And there is, at the ARVO, which is the National Association of Researchers in Vision and Ophthalmology, one of the largest concerns of those researchers is there is a lack of research tissue available for these cures.
Okay. Representative Loeffler.
Thanks. Just a basic question. What % of the donations are used for actual transplantation into another person, the gift of sight that I think most people envision when they're signing up to donate, versus what % go to research?
Yes, so at the Lions Gift of Sight, about 40% of the tissues that are procured actually go to surgical transplantation. About 60% is going to research or training for physicians.
Thank you.
I haven't visually seen anyone sign in. Have you guys? Did you guys sign?
Yes, we all signed in.
Beautiful. Visually. Okay, Representative Bonner.
Thank you, Madam Chair. I guess my question is, I noticed that when we were talking a little bit about monetization, and I'm curious. So, I don't know what, my understanding is that we're not actually selling these tissues, but that the fees being charged are associated with processing and storage of the tissue, correct?
Dr. Ho?
And is that correct for both Lions Gift of Sight and for the Sight Life?
Yes, so this actually speaks to my misinterpretation of NOTA. So NOTA does prohibit the sale of cornea, but it allows you to charge a reasonable payment for processing, storage, and distribution. Where the loophole is you're not allowed to have valuable consideration for the tissue, but you're allowed for reasonable payment. And what is reasonable payment is very vague and allows for a little bit of a loophole. So you could say that we both charge for our processing fees and stuff like that, but is it really exactly what it costs us to process? For instance, Sight Life is many times, maybe 4 or 5 times larger than our iBank, but they charge a slightly higher fee than us for their distribution. And they say, well, that's the expense for us to process, store, and distribute the tissue. And it is very hard to piece out exactly what is their cost, but that is the price that they say. So based on economy of scale, they're 4 times larger, they should be able to do it. You would assume cheaper, but their pricing is a little bit higher, but still the justification is that this is what it costs us. And because the current reimbursement structure is an automatic pass-through, whatever iBanks say it costs them is how much you charge the insurance, and insurance pays it. So it is a very lucrative loophole if you can establish a for-profit within this sort of reasonable payment structure. But it raises concerns. And eventually, if it continues to expand and all of iBanking becomes this for-profit model, I'm sure Medicare and Medicaid will revisit this and start to say, what is reasonable payment? And at that point, you start to really commoditize corneas.
Representative Bonner.
Thank you, Madam Chair. Thank you, Doctor. And I guess that I'm curious, and do we know, obviously I have concerns about this too, and what constitutes reasonable. That is a question looming in the back of my mind. And I'm curious, do we know about what the gap is between what's charged by Sight Life versus the Lions? I mean, is it like a lot more? Is it 10% more? Is it 20% more? Is it?
Yeah.
I'm curious what is the differential? And I, just to be clear, I do understand that the discussion is also around the loophole and how someone could potentially expose that loophole to charge larger percentages. I'm just curious what it stands at currently.
Yeah, I think we do have the numbers. It is not egregious. It's not like they're charging double or triple what we're charging. It is still within the range of what most nonprofit iBanks are charging. The question is, because of their economy of scale, could they actually be charging less because it actually costs them less to do it? The other thing about CorneaGen and Sight Life is that they also get some profitability from other mechanisms. For instance, CorneaGen also sells surgical devices, but they bundle their surgical devices with their corneal tissue. So then they approach surgeons and they court surgeons and they say, well, if you want to use this device, you have to use our tissue too, if you want to buy this device from our company. And it also, having basically access to corneal tissue as a for-profit company selling medical devices, they have access to more surgeons, and more surgeons come looking to them. Because of that access. So there are other mechanisms of profitability other than just simply the actual price that they're charging. And whether or not that violates valuable considerations, meaning is the cornea being used and are they obtaining some sort of valuable consideration beyond the reasonable payment? Again, it's a gray area and it's allowed the eye banking practice to go unchallenged so far, because yes, they can sell more medical devices because they distribute corneas. Is that a valuable consideration? I'm not sure.
Thank you.
Thank you, Doctor, and thank you, Madam Chair. So I guess I'm curious. So we said that
Representative Bonner, I know he has a flight. Do you have time for another question?
Yes,
or-
I have maybe like 10 more minutes.
10 minutes?
I apologize.
You don't have to take 10 minutes, but.
No. All right. Thank you, Madam Chair. Thank you, Doctor. So I think I do share your concern, particularly in the concept of the bundling and so forth, and those considerations. The one question, and maybe this is maybe not even for the doctor, maybe this is for a representative from Sight Life, if we have one, but I'm curious if that increased differential that they are charging right now, if there's some rationale for that increase, and if that is consistent with a new technology, is that for storage, or what is I guess I'm trying to understand what might be driving their increase. Is there some innovation that could be used by other tissue banks in storage that maybe is accounting for that price differential? I guess I'm just trying to understand the nature of the business and how it works and what happens.
Yeah, I don't think I can speak for Sight Life, but I think that would probably be one of their arguments, is that they're reinvesting it in innovation in their targeted market, which is corneal transplantation. But like I said, for 65 years, the eye banks have innovated and developed, and actually there's been massive improvements in corneal transplantation from full thickness to partial thickness to literally just a thin layer of cells being transplanted now for most corneal transplant surgery, all through a collaboration with nonprofit eye banks and their local surgeons. And so a justification that, we need to charge a little more so that we can now actually do real research, it rings a little hollow in the face of all the historical evidence that we have, in that nonprofits with collaboration with altruistic, surgeons and researchers have advanced this field beyond anyone's imagination. I may be a skeptic, but if it's a for-profit company with shareholders and the public intention to go IPO in 2020, I mean, you have to imagine that some of that upcharge does benefit the shareholders. Now, maybe not directly, but through inurements or other mechanisms, it's sort of benefiting them somehow. Like I said, I can't speak for Sight Life, and this is all my own personal opinion, and I don't have evidence of how they come up with their pricing, but that's what I would say.
Thank you, Doctor, and thank you, Madam Chair.
Thank you, Representative.
Madam
All
Chairman,
right,
if I
thank
can
you.
answer the question from earlier regarding which hospitals, we would be happy to provide a comprehensive list.
Okay.
So the initial hospitals were Alina, Mercy, Regions, St. Cloud. Within 2 weeks of the cancellation of our contract, we had lost 15% of our hospitals by volume. Within 6 months, we had lost 35% of our hospitals by volume.
Thank you, Mr. Popoff. Thank you for those numbers. All right, let's have Susan Gerdenson and Sue Helgrimson. Oh, okay. Is Mark McKee available to testify?
Mark, where's Mark?
Welcome to the Health and Human Service Policy Committee. Please introduce yourself for the record.
Thank you. Madam Chair and committee members, my name is Susan Gunderson, and it's my privilege to serve as the Chief Executive Officer with LifeSource. We are here today to speak in opposition to House File 1247. This bill is unnecessary, harmful to patients and donor families, and will stifle medical innovations and advancements. I am a lifelong Minnesotan, but I am first and foremost an advocate for donors and families who will be harmed by this legislation. In fact, this legislation is a solution in search of a problem, fueled by inaccurate information. There is no shortage of corneas for transplant or research, and there is no selling of eyes. To be clear, this is not a disagreement between us and the Lions. Our opposition to this bill is about protecting Minnesotans and following well-established existing state and federal laws. Our relentless focus is on serving donors and their families. Donors and families first, not parochial institutional protections. Donation is not successful because of one person or one organization. Rather, it takes many individuals and organizations working in close collaboration to make donation and transplantation happen. It starts with the family and a donor who generously say yes to helping others at their deepest, darkest moments of loss. These are gifts given with love and received with gratitude. LifeSource physicians, nurses, hospitals, regulators, DMV offices, medical examiners, and others all work together to honor those gifts and to save lives. I think it's important to say that the University of Minnesota is a founding member of LifeSource and has been involved in our collaborative work in transplantation and research for 30 years. In fact, together we have facilitated these gifts of life to 7,500 grateful transplant patients under their care. We do this work together. I was asked to start LifeSource 30 years ago and did so because of this noble and life-saving mission. 2 years ago, we accepted the long-standing request from hospitals and families to offer a comprehensive single point of service for all donations, organs, tissues, and eyes. We accepted that call with a keen focus on delivering streamlined care for donor families and the highest quality outcomes for recipients. Our eye donation partners are Sight Life and Dakota Lions Sight and Health. Both of these organizations are Lions-based and both distribute corneas to surgeons in Minnesota. Both have transplant success rates greater than 99%. Any claims of shortages of corneal tissue by Lions Gift of Sight, which you just heard, are really self-imposed. Our repeated offers to provide corneas to the Lions Gift of Sight for their vital work of transplant and research have been consistently refused. We understand some have claimed that eyes can be sold. This is simply not true. The National Organ Transplant Act of 1984 clearly prohibits the sale of donated organs, tissues, and eyes. And Minnesota state law further reinforces that through the Darlene Luther revised Anatomical Gift Act. The original misinformation, which you just heard about, as well as the corrected statements, are in the packets of information we have provided to you. The Uniform Gift Act was created to help donor families, not organizations or companies in donation or tissue processing. House File 1247 clearly benefits an organization and does nothing to benefit donor families. The GIFT Act creates vital uniformity across state laws essential for the success of donation and transplantation. And carving out for one gift a unique process will be problematic for donation. This legislation would put Minnesota out of step and, frankly, behind the rest of the country. Some have suggested that LifeSource coordination of eye donation services increases costs. There is no evidence to support this statement. Donation occurs at no cost to the family and no cost or reimbursement to the donor hospital. Cornea recovery accounts for about 20% of the cost of the transplant procedure. In fact, the biggest impact on cost is whether the procedure is done in an inpatient or an outpatient setting. And along with delivering top quality corneas for surgeons, our partners are making scientific advances to allow for more outpatient corneal transplants. Finally, this proposed legislation will limit the cornea options for surgeons, patients, and hospitals in this state. No one's needs are going unmet. Indeed, the supply of corneas exceeds the demand in Minnesota and the United States by up to 50%. Physicians determine the best plan of care for their patients, and we believe their choices should not be limited by a state line or a state law. Let the surgeons and the hospitals make the choice. Healthcare organizations regularly work with both nonprofit and for-profit companies. This legislation and any iterations related to tax status should not be a litmus test for partnership and putting restrictions around what could hamper research efforts and truly innovation in medicine. If this legislation becomes law, it will have a real negative impact on the families we support in the future. I might add a comment also about research. You've just heard that research has been severely compromised. We as an organization are entirely dedicated to providing organs and tissues and eyes for research if transplantation is not an option. Transplant always is the priority. We have offered repeatedly to provide corneal tissue to the Minnesota Lions Eye Bank. They have not accepted those offers, but that offer still stands if they would choose to accept that. So we all have a shared goal of saving lives and quality of life through transplantation. Minnesota has long been a leader in public policy for donation and has held a high standards of adopting policies based upon facts. On behalf of donors and their families, I hope you continue that legacy. There's been a lot of discussion around this topic. Please review the materials we provided to the committee, starting with the primary document, which is myths and facts. So in the end, it's all about families. I want to leave you with some survey data we received from families of eye donors who we've served this past year. On a scale of 1 to 10, 100% of families rated us an 8, a 9, or a 10 in supporting them at their time of loss. 100%. We are about caring for families, and we want to continue to do that work. I look forward to answering your questions. Thank you.
Thank you so much for your testimony. Mark, would you like to introduce yourself?
Yes, my name is Mark McKee, Madam Chair, members of the committee. It's a pleasure to be speaking to you today, and it's a pleasure to be part of this discussion as I'm not a medical professional policymaker. I am what LifeSource and I now refer to myself as a donor family member. My father, Patrick, passed away in November of last year. Very suddenly, very unexpected. He was a very healthy individual of an aortic rupture. I'm sure there are medical professionals in the room who know how unexpected and shocking that can be for families. So when we met at the hospital, my family was there together, and in addition to the shock and the rush of grief that comes over you, immediately logistics are a concern. What do we do? We're in a hospital. There are doctors speaking with us. As soon as we, possibly even before we got to the point of discussing concrete logistics, what to do with my deceased father's remains, there were two LifeSource individuals there who were first and foremost offering a lot of compassionate support and logistical support. My father was a registered donor, and that was a designation that he was very proud of. So our LifeSource contacts that day at the hospital, and then several weeks from there on out, were extremely positive. To the best of my knowledge, it's myself. I have two older sisters and my mother. They were a primary contact of advice as well as, information pertaining to his organ donation, the recovery, as well as the logistics to get him to his place of cremation in Wisconsin. So one thing I'd like to emphasize, the singular compassionate point of contact, this was something I thought of at the time, knowing that my dad's body would be undergoing some changes in addition to what one would typically anticipate in preparation for an open casket, that type thing. The call that we received from LifeSource informing us that the tissue and organ recovery went well and that those materials are from him were going on to help people, was really powerful for us in such a time of grief. They provided the information that his tissue from his eyes went to restore sight for 2 individuals. Again, I'm not a medical professional, but yeah, we received the information that connective tissue, bone material, some folks on both sides of the room might know, how that would help other people live full and healthy lives, and what a gift that is. So I'm going on a bit long, but the last point I would like to make is that as you know, as a family member, being a member of a family who the relationship was established, their status as an organ donor, that gift of donation, and our good fortune in interacting with LifeSource as part of that whole thing is the procedural mechanics of making sure that organs of those who have passed may live on in some sense to benefit others' lives. That's fantastic. I'm sure that a number of well-qualified medical professionals are able to accomplish that. But what really struck it home for someone like me, who's aware that those things exist, and that's awesome, what made the personal difference for me and my grief and memory of my dad is just the strong network that LifeSource fosters. The mechanics of organ recovery is something that they were really open about and communicative about, but then honoring the memory of your deceased loved ones was something that I didn't necessarily anticipate, but that has been extremely meaningful. Their campus in just on the northeast or north, I guess west side of the river of Minneapolis has a memorial wall with all organ and tissue donor names. We attended an event that the organization held, and many familiar faces over here from that event, including Susan, of course, was a gathering of donor families from all over the state of Minnesota and surrounding states. It was a cool ceremony. Everybody stated their loved one's name, got to speak with one another, spent some time looking at the wall. So I guess not having a deep understanding of how the policy is constructed between various entities who are in the business of recovering organs from deceased individuals, or I guess based on the last bill, sometimes living, but not having a deep understanding of that business, I would just as a lay person who has a passive but interest in policy as it's developed, approaching and throughout the legislative session, it seems like this proposal might just be an attempt to interject law into a market where I guess a record based on results we'll leave it there. But thank you for letting me share these words today, and that's all I have.
Thank you so much for your testimony. Yeah, sorry for your loss too. But thank you for being here today. So we have one other testifier left, and that would be Marcy Diamond. Okay.
Thank you, Madam Chair and committee. I am your last speaker. I know you're all relieved about that, and I promise to be fairly brief. Good afternoon, almost evening. My name is Marcy Diamond. I am the CEO of Dakota Lions Sight and Health, and it's an honor to be here today. DLSH is a nonprofit eye and tissue donor organization that has served 11 communities throughout contractual partnerships with hospitals in Southwest Minnesota for nearly 20 years. It is our mission to facilitate both the gifts of sight and health through eye and tissue donation, and we are deeply committed to the community partners, donor families, and recipients that we serve. And for this reason, I'm here to oppose HF 1247. DLSH feels strongly that proposed changes to Minnesota Uniform Anatomical Gift Act through HF 1247 are counterproductive to the intent of the uniform law and can be harmful to all donation. The proposed changes remove the ability for hospitals and surgeons to select a donation partner that is best able to serve their community by requiring them to work solely with one eye bank and creating a monopoly that also restricts free trade. This proposed change is in conflict with the intent of the Uniform Anatomical Gift Act, the uniform law, which was intended to provide a mechanism for individuals to designate a gift under their free will and to permit the free exchange of corneal tissue, which increases access to the gift of sight. In most cases, uniform law is drafted to provide a uniform framework to support systems that are already in place. Minnesota has a long-standing, effective system already in place to facilitate the gift of organ, eye, and tissue donation. This is evident by some of the highest rates of donation designation nationwide. Supporting a change to HF 1247 forces an individual to make an organizational specific decision that may not be relevant to the individual or the donor family, in effect complicating the decision to make an anatomical gift. This has the potential to negatively impact the choice to donate. As a Minnesota donor family myself, my family's donation would not have been possible without either LifeSource and, at the time, Minnesota Lions Eye Bank. And I'm not sure the decision that we would have been made if we had to choose between one or the other. And I was thankful that I knew what my mother's wishes were, and that was the only decision that I had to make. I've encountered countless families in my 22 years of working in donation. And more often than not, families are relieved to hear that someone has made that decision for them by indicating on their driver's license through the ability each state had to enact the Uniform Anatomical Gift Act. So today we're not really talking about the difference between for-profit, nonprofit. We're talking about asking people to indicate a specific gift to one organization. There was some talk today about the Eye Bank Association and their stance on the emergence of for-profit eye banking. And we are all navigating that change within the industry, but it's being navigated by the association and by the members. One of the committees that I am actively involved in is a committee that works directly with CMS to discuss changes to the pass-through. We are fighting to protect the pass-through, and there are only 5 pass-throughs. I'm not sure everyone here is aware of what the pass-through really means when we talk about that, but the CMS regulations allow for certain items that they deem critical to be considered 100% reimbursable. The CMS regulations for 2020 preserve the pass-through, and that allows us more time to study, as an association, the impact of for-profit and not-for-profits. EBA is deeply concerned about the changes in our community and how it will impact all eye banks and donation as a whole. One thing EBA has strongly stated and released a position paper on was their position against states regulating changes to the Uniform Anatomical Gift Act that restrict donation. I would encourage you to look into that. There was some discussion today about processing fees. I can share with you, I'm happy to share with you that Dakota Lions Sight and Health does survey other eye banks across the nation annually, including attempts to gain that information from Minnesota and from Cornea Gen Sight Life. The cost of reimbursement to an eye bank is roughly $200 to $300 different per cornea. So nationwide, there isn't a huge disparity in the cost of reimbursement for corneas. And as an association, we are fighting to maintain that at an equal playing field to the best of our ability. Lastly, I think it's important to share, as Susan Gunderson stated, DLSH does partner with many organizations to facilitate the gifts of donation, and that includes LifeSource. Not only through shared eye, organ, eye, and tissue donation, but we also receive corneas that are recovered by LifeSource, and in turn, they are able to be processed and distributed locally, nationally, and internationally. For these reasons, Dakota Lions Sight and Health opposes the changes to HF 1247. Thank you.
Thank you so much for your testimony. Questions, member? Representative Albright.
Madam Chair, you know, I'm not going to debate the merits of this right now, but it occurs to me that in my 8 years or so of being on this policy committee, I don't know that we've ever had a conversation about organ donation. And I think for the benefit of everyone, at some point, maybe when the next session starts, maybe we should focus some time on the protocol around organ donation, whether it be kidney, heart, cornea transplants. I mean, we're moving into an entirely different, some might say commoditization, commercialization, you can use any term, but I think we, as a body in the committee, should be vetted and briefed on what is going on in that industry. And so I feel a little bit unprepared to respond to my good friend Representative Baker's request, because I don't know that the context isn't there. So I appreciate, you know, the informational meeting, but I think there's a greater degree of context that really is relevant before we sit down and make a decision about policy in this matter, because it does affect people's lives for both good and bad, and I'm just at a loss for understanding how it all works. I'm sure I'm not the only one on this committee that feels that way.
Yep. Thank you for that. We noted it too. So, any other questions? Representative Lawford?
Thank you, Madam Chair. And this is a really basic question. Maybe it's after 5.5 hours of listening straight through. But I feel like the witnesses on this bill have talked about it from their business perspective and using kind of code words. And I need to take it back down to that family interaction. So if a family is in a situation like our one witness was, a sudden unexpected death, and they're approached about the potential for donation. If we have two different organizations, one of which takes eyes and one of which takes other parts, do they talk to two different representatives and sign two different sets of authorization versus one if there's, you know, a single source? Or is that all handled in the background and the patient really only deals with one person? I mean, just a really basic understanding of what's the difference between the two approaches.
Madam Chair, if I could, I'm going to take an attempt at this because I also want to let the committee know. Tony, Representative Albright kind of hit it on the head tonight too. This is an important issue that we should be talking about. It isn't so much about the profit, nonprofit. We don't want families making choices at that critical moment. That's not what we want to do. We even don't want to tell the hospital systems who they should choose. What we want to do as a state and as an association that we have to control healthcare costs is understand what actually does happen behind the scenes that I didn't know anything about until this bill came to me from a constituent in my area that has nothing but praises for the Lions Eye Bank. And there are people that have nothing but praises for LifeSource. These are both great companies. And I want to make sure, again, as I said before, this is not about that. We want to make sure, though, that as we have learned in the legislature about what are the costs behind the scenes? I'm a donor, but I have no idea who's going to pay for that if my organs can be harvested at that point. And I just want to make sure that we know that this is a complicated issue, and I I do hope we can have more conversations about this. We don't want to get into those kind of conversations, Representative Loeffler, and we just want to make sure that both organizations do a great job. LifeSource charges a little bit more currently than the iBank, and we want to make sure that those are recognized because it's our job to watch costs. Whether it's a pass-through or not, we just at least have to make sure that we're aware of that. But the costs increase, they're minor, but it's there. But we also know, do we want to talk about, should we not have any profit on these things? I think that's important for the state to know that because we have to control the costs. That's our job. So this bill is far from right. We are going to try to continue to get LifeSource and the Lions iBank to keep working together in collaboration. That's an important role that I've been trying to play actually behind the scenes. But this has been a good opportunity just to talk about this openly because this kind of thing is a drop in the bucket when it comes to the healthcare system. But our amazing medical science has done such good things. This is becoming something we need to become more aware of.
Madam Chair, may I answer the question?
Really quick, yes, please.
Thank you, Madam Chair and Representative. It's a great question. The quick answer is the family says yes to donation. The call comes to LifeSource. We handle all of the communications with the hospital staff and the family and have a single point of contact. That was the primary driver for why hospitals have chosen to work with us to have that single point of contact to best serve the families, best serve donation, to streamline that process. And I agree with the concept that we really need more conversation about that and would welcome that. And I'd also would just clarify that LifeSource does not charge for corneas at all, so there's no differential, and there's no cost to families, no cost to families at all for donation, nor to the hospitals.
Thank you, Ms.
Thank you.
Okay, Representative Bonner.
Thank you, Madam Chair. Thank you to our testifiers. I have a couple very pointed questions.
Madam Chair, excuse me. Phil Griffin,
yes.
Could we please go back to that previous question that Sean would like to give a slightly different answer?
You want to respond to Representative Loeffler's question?
Thank you, Madam Chairman.
Okay.
Madam Chair, excuse me.
Please reintroduce yourself.
Sean Popoff, Executive Director, Lions Gift of Sight.
Okay.
One phone call starts with a shared phone number between our two organizations. That number is 1-800-24-SHARE. That number is jointly owned by Lions Gift of Sight and LifeSource, to be clear about the one phone call. Now, I do want to bring one thing up. They have offered to drop tissue off at our door. And that offer has been met with no thank you. There's a lot of reasons for that that I can go into or not at this point in time. We have also made several proposals to LifeSource on how we can lower the barriers for families, and work with those families from a single point of contact, from the point of the first phone call when someone has passed away, all the way through honoring their life through an annual celebration. Those proposals have also been met with silence.
Thank you. Thank you so much. Representative Bonner.
Thank you, Madam Chair, and thank you. And I guess that was actually one of my first questions is, there was some discussion about why you weren't accepting some of those tissue donations, and I guess that was one of my big questions is why not? I'm not quite sure if that's just a matter of having a deeper conversation to work out the details there, or what's behind that? Because I'm curious.
So the primary reason behind that is, sorry.
Popoff?
Sean Popoff.
Yes.
The primary reason behind that is we have a 60-year legacy of doing this, and we're really good at our job. Families love us, researchers love us, surgeons love us. But death to preservation is one of the most critical things, especially when it comes to research tissue. Cornea transplant is the priority, absolutely. But if you recover a cornea and it's not suitable for transplant, it's great that it goes to research. We recover not only corneas, and some of those corneas do go to research. We get back a lab result that says, can't use this tissue for transplant, we'll shift it over to research immediately. We also recover whole globes, the whole globe. We recover whole globes everywhere, and that's what researchers need. So if you're recovering the cornea for research, that doesn't help you with age-related macular degeneration. It doesn't help you with glaucoma. It doesn't help you with retinal diabetes. This bill is not about limiting choice either. There's 3 eye donation agencies in the state of Minnesota. The amended bill that I would let Representative Baker speak to doesn't name us. There's 3 agencies in Minnesota with eyes: Dakota Sight and Life, LifeSource, and Lions Gift of Sight. This bill doesn't preclude any of them from being here. Surgeons can go anywhere they want. I happen to serve about 93% of the surgeons in Minnesota. Some of them get their tissue from CorneaGen. I'm fine with that. I'll compete with them. But the primary reason we do not accept tissue dropped off at our door is death to preservation matters, and we're faster. We can get, and especially in research, sometimes I will use our good partners down at Mayo as an example. We recover research tissue for their glaucoma program that never comes back to my facility. Death to preservation is 2 to 4 hours on that tissue. We can recover the tissue, drop it off at Mayo in that time frame, and advance their sight-saving research.
Okay, Mr. Popoff.
Yes.
So just for clarity around what I think I'm hearing, the biggest issue or concern and why this bill has come forward is around the tissue and the research. That doesn't happen with LifeSource?
That is a decision by SightLife, one of their tissue partners. SightLife takes corneas for research, and to be honest, I hope they put us out of business. We enjoy the same success rate as Dakota Sight and Life and CorneaGen. We're 99% successful when you look at our corneas for transplant. I hope that they reach their goal of putting everyone out of business, but of curing corneal blindness by 2040. It's a laudable goal and one I hope they accomplish, but they don't recover whole globes for research.
They don't recover.
They do not.
They do not. Yes. Okay, Representative Bonner.
Thank you for that, Madam Chair. And Mr. Popoff, and I don't know if we have someone here that can speak for LifeSource, but the information I had is that they do in fact have whole globes available for research. And I don't know the time differential in processing that from them dropping it off versus you doing it yourself. I don't know if we're splitting hairs here. I don't know. I'm not really sure what the difference is, or if someone knows the answer to that.
Ms. Gusterson.
Madam Chair, Susan Gunderson, we do participate in recovery for whole globes for research as well. The matter of timing, I think, is perhaps splitting hairs and not the level of discussion that the committee necessarily needs to get into. There are no reasons that we would not be able to provide the same timeliness that Mr. Popoff has alluded to. We have the highest quality scores for all the recoveries that we have been performing, and we are confident we could do that as well with the University of Minnesota. We are just not sure why those offers have not been accepted. Thank you.
Thank you, Madam Chair.
Bonner.
Thank you, Madam Chair. Thank you. I guess one of the things, and this is maybe just a commentary here, I mean, I don't know where the discrepancy lies in the two of those. I want to say, first off, that I've worked with the Lions on numerous occasions and have had some discussion around this very issue with some of the Lions in Maple Grove and Osseo. And I just, to me, this feels like an issue that could be resolved between LifeSource and the Lions with some greater discussion. And my first thought, to be honest with you as a legislator, is I would encourage you both to get back to the table and have a discussion around that, because I feel like it's something that could be resolved outside of this committee and outside of this council. So that's one thing. And I want to say that I think the Lions, I speak very highly of them. They do amazing work in the community, and I would never doubt that for a moment. That said, I also know that LifeSource is an exemplary company who does incredible work with families when they take care of tissue donation. I know that there's a great deal of time and care placed on building those relationships with families, with potential donors, to really reach out, as one of our testifiers mentioned, and make sure that families are comfortable, that the donations received are really treated with the utmost care and respect, that the families are treated with that same amount of care and respect. And I guess one of the other questions, though, and this is maybe more for when we talk about CorneaGen or SightLife, there was some testimony earlier that there may be a suggestion that there is sometimes some bundling or packaging of if you buy our instruments, you should buy our instruments and buy our tissue, for example. I don't know if that is accurate, but I will say up front that from a for-profit standpoint, for talking about the potential for abuse, I have serious concerns about that particular item. That also seems like something that maybe should be looked at outside of this, but if not, perhaps there is legislation that should be put in place to make sure that we forbid that bundling, so that that cannot happen and that we cannot potentially abuse the system to create a for-profit model that is counter to, I think, what we're all trying to do here today. That, to me, is problematic. And I really want to make sure that we aren't incentivizing some sort of a for-profit commercialization of something as incredibly important as tissue donation. And I think all of us in this room would agree on that particular point. So thank you for that. There was one other last question, and then I will let it go, and that is there's some question about which company is used for the donation. And there's also some language about high quality matches and the surgeon's ability to choose which is the best quality match for them and blah, blah, blah. And I guess one of the things that's a little concerning about that language for me is I'm trying to understand, first of all, how do we assess the quality? I don't know how we do that. Are we talking about apples to oranges here? Because it feels like, from what I've heard in the testimony, that each of these three companies do exemplary work in determining the quality. And so I guess that argument for me doesn't hold a lot of water, because I feel like I'm getting the sense that all three of these organizations do incredible work when we talk about quality. And so I'm just trying to understand how that plays into that, or if that's maybe something that really should be removed from the language here, because it might be just dividing things that really shouldn't be.
Can someone respond to that, or okay, please,
Madam Chair, Marcy Diamond, Dakota Lions Sight and Health. Quality of corneas is really determined based on a number of factors: death to preservation, number of cell count, and then surgical recovery, meaning no stress lines, and which occurs when you handle the cornea. Because of the surplus of corneal tissue for transplant, surgeons have been able to become far more selective in what they'd like, limiting disease processes that they don't want to receive. And so for each eye bank across the nation, not unique to Minnesota, South Dakota, North Dakota, we are all faced with having to increase quality and offer better quality tissue, lower preservation times, higher cell counts to surgeons nationwide in order to place our tissue for transplant.
Sean Popoff, the only Lions Gift of Sight, the only thing I would add again is I agree. We're all in the 99% plus. Primary measure for us is a failure. It is a failure in the transplant to take and clear, and if that doesn't happen, we consider that a failure. But I don't think the quality of the three between CorneaGen, Dakota Sight and Life, and Lions Gift of Sight, I think they mirror one another.
Thank you, Madam Chair, and thank you to the testifiers for those questions. I really appreciate the patience with which you were able to answer my questions and the thoroughness with which you did. Thank you.
And I, too, would like to thank you all for coming out to testify today and spending the afternoon, evening, some of the evening with us. So that ends our hearing. I want to remind everyone you have the expense reimbursement form in your folder there. So if you'd like to be reimbursed for today, please fill it out and give it to Chris before you leave. One moment, guys, one moment. I just want to say to Representative, we have not adjourned yet, so give me a moment. I would like to say to Representative Baker and all those concerned with this bill to please try to just get together and work it out. That was the purpose and reasoning for having the informational hearings today, is to get those all primary stakeholders together to talk a little bit more about, how we should, or if we should move forward on bills, but to work it out.
And with that, Madam Chair, I want to just add as a closing statement, that was the intent of this today, was to bring out some real good companies and their models doing it very similar, but we want to make sure we find a better way to bring this together. I hope we someday don't need legislation to do any of this, but we're going to continue to work together. I know that we've got really good hearts in the right place from both of these organizations. And again, I will be happy to answer any other questions. And if you have other comments, members, from what you've heard today, I am all ears because I want to try to make this thing work as well. So welcome to my world on this issue. It's not easy, and we'll try to bring you more information as it comes up. But thank you again for your time on this. Thank you. Thank you.
Well, with that, we are adjourned. Thank you.